Welcome, everybody. Good morning. Margaretta Brandt, Assistant Deputy Director for Health System Performance at the Office of Healthcare Affordability, and welcome to, I think this is our 9th meeting of the OHCA Investment and Payment Work Group. So again, as I mentioned, as you're joining, please introduce yourself in the chat so we know that you are here. And of course, joining me this morning are members of the OHCA team and our partners at Friedman Healthcare. Today, just a quick overview of our agenda. So we'll start with welcome and updates. We do have a membership update we wanted to share with you all. In the first part of our meeting, we'll discuss board feedback on the alternative payment model standards and goals when we presented those to the board in February. And then in the next portion of our meeting, we'll discuss advisory committee feedback on primary care measurement and benchmark options, which we discussed with the advisory committee yesterday. And so before we jump into our first agenda item, wanted to give an opportunity for to share an announcement that Cindy Keltner from CPCA is retiring soon. So Katrina Reyes from CPCA will join as representing on the work group moving forward. So really thank Cindy for all of her contributions to the work group, and congrats on her retirement. And want to pause to let Katrina introduce herself to the group.
Good morning, everybody. I'm Katrina Reyes. I'm the Deputy General Counsel for CPCA. I was on the advisory group for that first meeting when I was with CAFP. Hi, Lisa. Nice to see you. And I look forward to working with this group again.
Great. Thank you, Katrina. So our next slide is just a quick reminder of the meeting format. And again, a reminder that we appreciate all of your feedback in the chat or comments in the chat, and we use those to inform our work moving forward if we're not able to address all of them in the meeting itself. And then also another quick update, wanted to share a timeline update for the primary care and alternative payment model work. So as we mentioned, today we'll share feedback from the advisory committee on a few key discussion items we had related to primary care measurement and primary care benchmarks. And then with your input today, we'll revise the primary care recommendations to bring to the board in April. And then we'll share board feedback here in May and revise and then also bring to the advisory committee, and then eventually go back to the board for final recommendations for final approval in July. And then the alternative payment model work will follow a similar cadence with the board for approval in June. So I think with that, unless there are any questions, I'll turn it over to Non-Tran to walk through our first agenda item focused on the board feedback on our alternative payment model adoption goal.
Good morning, everyone. We'll just go ahead and get started with our first agenda item to discuss the feedback from the February board meeting on the APM standard and goal. Let's go to the next slide. So here we'll start with reviewing the recommended APM adoption goal we share with the work group in November and with the board in February. The draft absolute adoption goal was the same for all payer and product types, with interim milestone, which recognize differences in starting points. The stair-step structure shown on the slide provide a path for each payer type to reach the 75% of member attributed to the ACP land category 3 and 4 arrangement by 2034. Let's go to the next slide. On this slide, we provide a high-level overview of the feedback from the board that based on the draft APM goal that we share with them. To start with, the board recommended shortening the timeline, feeling that 10 years is too long to wait, considering we have been discussing considering we have been focused on increasing APM adoption for quite some time. The board also noted that recognizing existing differences in starting point across payer and product types may lead to different endpoints. Furthermore, they also expressed a desire for the goal to address challenges with APMs that exist today. More specifically, they share that APM should address hospital costs in a more meaningful way. Also, APM often don't offer provider enough opportunity to earn additional revenue or sufficient flexible payment to transform care delivery. And the last thing was APM have varying terms and quality measure that would make it difficult for provider to successfully engage. Next slide. So based on the board feedback, we are proposing the revised adoption goal and interim milestone. This potential approach shortened the timeline for all payer from 10 to 5 years, while increasing the goal for commercial HMO and Medicare Advantage and lowering the commercial PPO goal. The interim milestone for commercial PPO plans follow a 5% per year increase, which is similar to other payer types. This is to recognize the time it takes to move the payer provider contracts into APMs. While the commercial PPO goal is lower than other payer types, it more than doubles the number of members attributed to ACP land category 3 and 4 based on Integrated Healthcare Association data that we review with you in November. We did not revise the goal for Medi-Cal, but shortened the timeline. These revised goals are also under discussion with sibling state departments, which would ensure alignment and coordination. Next slide. We'll now pause here for a discussion on these questions and any other feedback from the work group based on what we presented so far. Our first question is, does the work group have feedback on the revised APM adoption goals and timeline? And then the second question is, does the work group have suggestions for addressing challenges with APM raised by the board, such as hospital costs, flexible payment, quality measure, etc.?
Thanks, Nan. Want to, open it up for discussion, and I heard, or I saw Crystal's hand first, so go ahead, Crystal.
Good morning, thanks. A question and then maybe a response. If you can go back to the slide with the numbers, why is commercial PPO so much lower? Like that seems like such a gap, and we'd be wanting to reduce the variation. I can see the board's point that they're all not going to get to the same point in the end. But I would love to hear more about that, and then I'm going to push back on it.
Sure. So first, recognizing that the commercial PPO plans are in a different starting point. So based on the IHA data of APM adoption for categories 3 and 4 in commercial PPO, I think that was around 16 or 17% currently. So this would, by 2029, look to double commercial PPO APM adoption for categories 3 and 4. The other thing some folks have brought up is that these recontracting decisions take several years. So making a 5% change over 1 year can be quite extensive and quite a lift. But appreciate the feedback and the pushback. So go ahead, Crystal.
Yeah, so I would argue it actually is it's a lot easier to do on commercial PPO than some of the other ones, and several of the health plans are trying that out right now. So I wouldn't say it takes 2 to 3 years. That's actually the commercial PPO is the opportunity where you have to move faster and do that, and given such the low performance level and that it's not as big as some of these other populations, you should see that percentage increase faster over time. And if we really want to address hospital costs, we need to look back at commercial PPO being a huge contributor of that. So I would propose, my proposal is that we keep an eye to reducing that variation and not let commercial PPO skate by. So if we set a year one of moving them to 25%, increasing that to 40, then 55, and a 65 and 75, knowing that kind of the general rates of improvement, and I speak generally, like you see a big uptick and then that you hit a plateau and you see some incremental improvement. But that would get commercial PPO to 75% and closer, as well as giving them, an incremental glide path. I'll type this in the chat.
Thank you, Crystal. And I think the next hand raised I saw was Beth.
Yeah, I think so I'd like to see commercial PPOs get closer to that 75%. I will leave it to others to say how fast that can happen, but I think moving the shortening the timeline, I understand. I also understand that if it takes a little longer for commercial PPOs, then we should, you started off with 10 years. I don't know why we can't, push hard to move as fast as we can in the next 5 years, but also have an eye out a little further if we need to. So, and I also, the other point I'd make is I worry about migration between types of plans. We've seen migration from HMO to PPO or PPO to HMO over the years, and I think that's something to track as part of this, is how much enrollment, both by purchasers and consumers, do you have in various, on the commercial side. Thanks.
Thank you, Beth. And yes, Adam.
So I'm going to push back a little on the commercial PPO. We should move. I would love to move faster. I have been involved with 5 different commercial PPO ACOs, and getting the structure correct can be a challenge. And several of the plans are still in a ACO structure that is much more similar to the problems that we've had with ACOs in the past. I think transitioning the current formats of those ACOs is going to take a little bit of time for the plans to figure out how they should look and to work with groups to get there. And the adoption, because of the contracting, does take a while. And I think making it, I would love to see it move faster. It's just if you move too quickly, there is a risk because of those formats, unless we provide a standard template for how those could or should look, that there might be some movement too quickly, and it's going to cause some unfortunate outcomes to the groups that are participating, where they may no longer want to participate because it ends up not being a great way to go for moving the needle and adopting these new APMs for the long term.
Thank you, Adam. It looks like Carrie, I saw your hand raised. Go ahead.
Thanks. Yes. Just, align my comments with Beth and Crystal on the commercial piece, although I appreciate the other commenters as well. If we're having different milestones for commercial than for others, I would also just want to stress the importance of reporting. I think we need a better handle on, what's sort of happening underneath the surface. It's not just, not just the plan level data, but where are, where are there examples of practices that are, doing adopting more APM strategies and goals? How do we actually get to that level of data so that we can understand, where there are differences marketplace differences or other differences, and we can begin to change those. So I just want to put a fine point and a stress on that, because I think, people, I think we need a better understanding of what is happening, if we're going to, think about setting different standards, which I'm not a big fan of, but thanks.
Thank you, Carrie. And yes, we can definitely kind of look into, and especially look to those in this on this call in terms of what's happening at the provider level in terms of who's adopting APMs and things like that. So I think there's a lot of work going on already across the state, and we can look to, amplify and or point to some of that work. I guess, Beth, did you have your hand raised again, or?
No, sorry. Thank you.
That's okay. Joe, do you want to jump in?
Yeah, thank you so much. Joe Castiglione, Blue Shield of California. I think in general, we are supportive of a higher benchmark for commercial PPO. I'm not sure about 75% in 5 years. I think that's something I'd probably want to talk to the rest of my team about, but I do think that we could probably be more ambitious than 40% in 5 years. But a couple of questions that I think would help us better understand what's realistic. And I apologize if you already answered these in other forms, but the first is, are self-funded products included? So that's A, and then B, it looks like the table is for membership. And so this is for all members, not necessarily or exclusively, I'm sorry, members who've sought care. Is that right?
Yeah, it would be percent of members, all members.
Okay.
And then in terms of self-funded, so from my understanding, and we may have to come back to that, is that reporting is essentially like, up voluntary, that we are asking the plans to report self-funded data to OHCA, but they would be included in the reporting if it's reported. And I don't know if Jill or any others from the OHCA team want to correct me on that.
I think that's right, Margaretta, and that's obviously an issue for the legal and regulatory folks to have the last word on, but some of the issues that all of you are familiar with related to ERISA and the constraints on state ability to require data submission come into play here.
Yeah, so a couple more comments on that. So, I've been explicitly asked not to share our interpretation of the issue around ERISA, but I just want to highlight that there are, at least from our perspective, potentially some issues with respect to moving populations for self-funded books of business toward Category 4. Category 3 is a separate question, but at least Category 4, we do have some concerns about, just given what we perceive to be regulatory barriers. And then 2, just a comment on the membership issue. So totally understand the perspective on it being all members. Just want to highlight that I think the feasibility of these benchmarks is significantly impacted by the idea of all members, particularly in a PPO environment, rather than just members who sought care, because we have a significant share of PPO members who just don't seek care in a given year. So I'm happy to get more information or more data on what that share of our membership is in a given year who do not seek care. But I do think that makes it much more difficult for us to attribute those members who do not seek care to an alternative payment model. So just want to highlight that the impact that may have on our ability to meet higher benchmarks, which again, we support given the constraints that I just shared.
Thank you, Joe. And I guess if I could dig into that question a little bit more about members who seek care versus those who don't, is that based on like the attribution approach to like Category 3 models in a PPO, or?
Yeah, that's correct. So the members which we can actually attribute to a given provider who's in one of these models, we just can't attribute those members if they're not seeking care, right? They're just not they're not seeking care, okay. So they can't be attributed to providers. So just want to call that out.
Do other folks have reactions or suggestions to these revised goals?
This is Adam Tallman, and maybe I should know this. Once we get to the point of expecting these adoption rates, what support would groups and insurers get to help make sure that they have the roadmap to getting there? Because right now, each plan is approaching this differently, and that is a huge challenge for adoption ultimately, as well as success.
Sure, good question, Adam. I mean, I think there's a lot of industry efforts going on currently to improve coordination and collaboration across health plans and to support them, you know, like the initiative that Crystal mentioned with that CQC, PBGH, and IHA are working on. And then I think, I mean, as OHCA is moving forward, our intention is to provide technical assistance where needed, you know, point to the standards, emphasize the standards, collaborate with our partners across state departments to aim to support plans to get there. So I think there's a lot that's still to be determined in that area, but it's definitely something we would support. So maybe moving back to our second question, are there any other suggestions for the alternative payment model work in terms of those challenges raised by the board of hospital costs or flexible payment? I think we've addressed some things like quality measures and flexible payment in our alternative payment model standards, but welcome any other suggestions. And Angela, go ahead.
Hi, thank you. So I just wonder, have OHCA considered measuring percent of spend instead of percent of membership? I think if you measure percent of spend, that you would be then able to capture hospital costs more broadly. And also, you know, I think the initial challenge that Jill had mentioned earlier about, you know, in the PPO space, there's a difference between attributed membership versus just plan total membership. I think if we measure spend, that would sort of account for it. So just a thought.
Thank you. We can look into that. I think that was on part of our considerations early on, but based on earlier work group discussions, moved to percent of members. But we can go back and look into that more. And I guess Vinayak or anybody from the OHCA or FHC teams want to speak to that? Okay.
I'm happy to speak to that, Margaretta, if you'd like. Can you hear me okay? This is Mary Jo.
Yes.
Great. Thanks so much. Yes, we did consider whether or not to measure based on percent of spend, percent of members, or actual non-claims payments paid out. And the decision was made earlier to go with percent of members for a few reasons. One is we thought in the work group shared that it really sort of better reflected the goal to address population health and to try to get sort of as many people in the pool as possible. There was also an interest in exploring, focusing on the actual non-claims payments paid out, because that was really to address this issue of often a lack of or an inadequate amount of flexible payments paid to providers. However, that's so different from how some other states are doing it that we thought it'd be difficult to set benchmarks related to that. As you know, and as many of the folks in the group may know, HCP LAN actually does it as a percent of total spend, but that gets tricky too, because essentially if you have any contract dollars associated with a specific category, then all of that moves over, and it doesn't really give you sort of a sense of the meaningfulness of those payments. So for example, you could have a risk settlement payment that is quite minimal, and yet you have sort of all of this total spend dollars move over. So the decision was made earlier on, at least preliminarily, to go with percent of members, and that's some of the rationale that was discussed at the time.
Thank you, Mary Jo. So let's see if there are no other questions or suggestions. I know there was lots of discussion in the chat, and we'll make sure to follow up and look through all of that. I think just to Robbie's most recent question, so we do plan to release an updated version of the standards and the alternative payment model adoption goals as we're bringing them to the board. So we don't have a specific timeline on when we would release the next version of standards, but we will definitely present a revised proposal to the board for APM adoption goals, and our plan is to do that in April. So we'll take the feedback that we heard today and probably also do some follow-up discussions and dig into that more to present revised APM adoption goals to the board in April. So if folks have additional suggestions on the revised goals presented today, we definitely welcome those as follow-up and appreciate the feedback we've collected so far today. So I think because we also have a lot to discuss on primary care and we want to dig into all of your feedback there, I'll keep us moving. So thank you all for your feedback on the alternative payment model piece. So I will now turn to discuss our advisory committee feedback on primary care measurement, the definitions, and the benchmarks. So we presented a draft recommended definition of primary care to the advisory committee yesterday. We also shared our approach to identifying primary care non-claims payments, and then also shared our the two options that we previously reviewed for setting a primary care investment benchmark. And we got lots of feedback from the advisory committee, so wanted to quickly kind of review what we proposed and the feedback that we got, and then open up for discussion with the work group. So I'll turn it over to Debbie Lindis and have her walk us through this feedback.
Thanks, Margaretta. We can have the next slide. So these next two slides provide a high-level overview of OHCA's recommendations for measuring primary care investment paid via claims. So the first three recommendations are that we should include a broad set of providers to reflect the statutory goal of promoting team-based care, that we should restrict some places of service to reflect the work group's vision of promoting continuous and coordinated primary care, and that we should include an expanded set of services to encourage that as much care as is possible and appropriate be delivered in a primary care setting. Next slide. This slide reviews the final two recommendations for measuring primary care investment paid via claims. So OHCA has proposed to include some OBGYN services as primary care, consistent with similar services included for other body systems. And preliminarily, we have recommended to exclude OBGYN providers as primary care providers, consistent with the work group's focus on providers who provide care for the whole patient. This recommendation is the same preliminary recommendation we made during the last meeting, and we'll review another slide that dives into some of the questions that came up then, as well as sharing advisory committee perspectives from yesterday. and we'll request your input specifically on this item when we open up for discussion. And then finally, OHCA is recommending including a limited set of behavioral health services when provided as part of primary care as a module. And the modular approach allows the associated spend to be added to calculations of primary care spending or behavioral health spending while avoiding double counting. Next slide. So this slide outlines the approach OHCA has developed with input from the Department of Managed Healthcare and other stakeholders to add some nuance to our identification of primary care providers. OHCA is recommending a two-step approach to identifying PCPs that uses the provider's taxonomy and, where available, their designation as a PCP in the Department of Managed Healthcare's annual network reports. So first, at the top of the flowchart, payers identify claims with a primary care provider taxonomy as defined by OHCA. And then if the primary care provider taxonomy is for a physician, a nurse practitioner, or a physician assistant, the payer then confirms that that provider is included as a PCP in the DMHC annual network report submission. So for example, an internal medicine physician who's not identified as a PCP in the payer's annual network report would be removed at this step. If the provider is identified as a PCP, or if the primary care taxonomy is not one that's tracked as part of the annual network report, then the payer moves on to confirm that the place of service and the service itself are both included in the primary care definition. Next slide. So I'll take a moment to summarize what we've heard regarding OHCA's preliminary recommendation to exclude OBGYNs as primary care providers. The recommendation is intended to align with the workgroup's emphasis on providers offering continuous whole person care. So for example, a patient who selected an OBGYN as their PCP would likely seek treatment for minor acute conditions like a sinus infection from another provider. And similarly, many people with chronic conditions such as hypertension or diabetes do not get care from an OBGYN for those conditions, whereas other PCPs would manage these conditions within their practice. Stakeholder feedback on this recommendation so far has been mixed. Many have shared strong support for this approach as aligned with the workgroup's vision of primary care. Others have shared concerns about conflicts with the Knox-Keene Act and other policies that allow patients to select OBGYNs as primary care providers. And some stakeholders have also noted concerns regarding the potential impact on women's health equity of excluding OBGYNs. Next slide. So here I will summarize what the advisory committee had to offer on this subject. So of the 6 committee members who commented, 4 of them supported OHCA's preliminary recommendation to exclude OBGYNs. The reasons they offered included that OBGYNs often consider themselves a surgical specialty, and they generally get little training to provide whole person comprehensive primary care. 2 members noted that OBGYNs within their provider organizations don't provide the broad spectrum of care that PCPs are expected to provide. And one of them offered as an example their own experience that OBGYNs, PCPs, typically refer care for common conditions back to other PCPs within their organization. For the 2 members who supported including OBGYNs as primary care providers, their primary concern was about the divergence of OHCA's definition from statutory precedent and from DMHC's definition of primary care. Next slide, please. So we'll pause here for discussion on these questions. First, do you have any additional feedback on any part of the recommended definition of primary care? And specifically, we'd like to hear your feedback on this recommendation to exclude OBGYNs in our definition. I'll open it up.
Thank you, Debbie. Any additional? Yes, go ahead, Beth.
It's pretty rare that Health Access agrees with Hill physicians and some of the other physician representatives on the advisory committee, but in this case, we agree that it's not appropriate to include OBGYNs. We were the organizational sponsor of the existing law. Our understanding is that in most instances, OBGYNs choose to be categorized as specialists rather than primary care providers. And so I do think that we would support the recommendation. And happy to answer questions or have discussion.
Thank you, Beth. Janice, go ahead.
Janice Rocco on behalf of the California Medical Association. I did post for folks into the chat the letter that was sent from ACOG to OHCA after the last discussion that we had on this topic as a group, just as some additional feedback. I also wanted to say, as was mentioned in the presentation of this, one of the other concerns that has been raised, including by me, is the equity issue. And I really think that we need to consider that thoroughly. Any type of discrimination would be inadvertent, but we do have women and others in California and throughout the country who choose an OBGYN as their primary care provider. And for many years of their life, that may be the only provider they see at all. Their primary care needs are being met. Their whole person needs are being met by the OBGYN. Now, that's not the case for everyone. And the alternative proposal was simply to include the issue of when somebody is seeking their primary care from their OBGYN to have that actually included in the calculation of in the definition and ultimately the calculation of what is primary care. And earlier this week, I saw that President Biden issued an executive order because we still as a country are not in a place where we are addressing women's health needs in an equitable fashion. And so he felt the need to issue an executive order advancing women's health research into federal research initiatives, including funding to equalize attention to men and women's health across their lifetimes. So we're still at a place where we often inadvertently aren't addressing women's healthcare needs as they should be. And I don't want to have a decision made here that's contrary to the statute that allows women to choose OBGYNs as their primary care providers. And then to say, that if that's where you're getting your primary care, it doesn't count. I just don't think that's a good decision. So I felt the need to say that one more time.
Thank you, Janice. Yes, appreciate that. Catherine.
Thanks, Margaretta, and good morning, everyone. Really appreciate the opportunity to hear the feedback from the advisory committee. I don't think anything that was shared there changes the opinion I hold or what we had discussed last time, and continue to support the exclusion of OBGYNs. I will put in the chat again the definition of high quality primary care services and providers that was endorsed by NASM and that is used in practice within California. I think important to note, because this has been such a sensitive and controversial issue, that inclusion or exclusion in a spending definition does not have any determining practice on what women choose for themselves or their families in terms of where they're accessing care or getting care. It's what is included in a spending target definition and a math equation. And so would just request that that be noted and publicized, because I think there's a risk of confusion about who you can go to versus what we are going to count and track over time. But again, to restate, OBGYNs provide exceptionally important care. They do not serve the whole person. They do not provide longitudinal care. They do not provide comprehensive or continuous care. And those are the core definitions of primary care. Thank you.
Thank you, Catherine. And Yes, I mean, I think in any reporting that OHCA would do, we would contextualize our definition of primary care and, share what we are measuring, what we are not measuring. I think we also potentially have an opportunity, and we can follow up internally on this, is to kind of dig into the HPD data to understand kind of primary care provided by OBGYNs or some other maybe contextual factors that would be helpful. So yes, appreciate that flag that, the context is important. So Kevin.
Yeah, I 100% agree with Catherine's comments and our current position that has been put forward. I appreciate the concerns, and I think it is an empirical question that we could test moving forward. I think I wouldn't put it in at this stage, but I think with the claims database now, one can actually look at gynecologists and see, are there gynecologists who are addressing comprehensive problems outside of reproductive tract or during pregnancy? And if so, I would be open to modifying my opinion, but I think the prevailing understanding is that rarely happens. I think actually when it does happen, it's usually a nurse practitioner or physician assistant in that office, not the actual gynecologist physician most of the time. So I would keep our current recommendation and then say moving forward with the payer database, we could then examine this in a more objective way.
Thanks, Kevin. Adam, go ahead.
I almost put down my hand after Catherine spoke because she said pretty much exactly what I was going to say. So I'll cut them more shorter. What we're looking at is a benchmark. This isn't telling women or anyone where they should get their care. It's not discounting the value of that care that's being provided, but we're looking for a stick to measure movement towards holistic care. And in general, although OBGYNs provide a wide range of services that overlap with primary care, and in my experience, it is not the kind of thorough, holistic, comprehensive primary care that we're discussing that we want to move patients towards. And so using that as part of the metric wouldn't help us in calculating how far along in that direction we're moving. At the same time, I don't think including or not including it is going to really change the volume of services provided by OBGYNs. And so in the end, I don't think it will matter that much. It will slightly dilute the total number, but it will, even if included, will still allow us to measure the movement in the direction that we want to go. So I'm okay with either way, but I support our original proposal.
Thank you, Adam. And Beth?
Yeah, I just put in the chat, since there's been so much discussion about the existing law, what looks to me to be the relevant provision. And I think the important part here is, that yes, OBGYNs can be designated as primary care, but that means, in the words of the law, someone who has responsibility for providing initial and primary care, for maintaining continuity of patient care, initiating referral for specialist care, providing for the majority of healthcare problems, including but not limited to preventive services, acute and chronic conditions, and psychosocial issues. So that really speaks much more to the kind of definition of primary care that I think this group has been focused on. And we certainly acknowledge the women's equity issue as part of the reason we supported that law. But I think we're trying to move, that law was enacted in 1995. We are trying to move forward to really centering comprehensive primary care. And I don't think, and we can all look and read further, but I don't think that excluding OBGYNs is contrary to the law, unless is contrary to the law as I read it. So thank you.
Thank you, Beth. And Carrie, I see your hand next.
Thanks, Margaretta. Just, again, not much more to add than what others have said, but I just want to be mindful here that we are looking at, the current state of primary care spending. I understand that there's, questions around women's health and the important role that OB-GYNs play. And of course, we're, supportive of that framework and concept. But what we're really trying to understand is how much money is going towards primary care. And from my point of view, and I'm not as studied maybe as other folks on this call, but an OB-GYN, who's a specialist who provides a certain type of care could potentially charge more than a regular primary care provider. And then you've got, inflated cost here for primary care when what I think we're really trying to understand is, what is the prevailing spending look like for primary care, and are we actually, spending enough on, basic preventative services? And that's and so just for all these reasons, I mean, I agree with what others have said, but I think, and Catherine, for reading the definitions, I really encourage us to stay focused on, the goal of what we're trying to accomplish here, which is a very, a real look at what we currently spend and how we are prioritizing or not prioritizing services for primary care and the primary care providers that provide them. So that's just my additional thoughts. Thanks.
Thank you, Carrie. Joe, please go ahead.
Yeah, no additional reasoning I want to share, but I did want to just provide some vocal support on behalf of Blue Shield of California for excluding OB-GYNs at this time. We are in favor of this, of trying to drive resources toward this sort of vision of advanced primary care that was so perfectly outlined by Catherine and others on the call here. I would say, however, that we would be interested in learning more, or at least trying to better understand. I think maybe it was Hillary's comment in the chat that just looked at what a potential for a secondary or supplemental definition might look like and what spending might be associated with that second definition. I think that this issue where there are additional services that are not being included is not exclusive, as we all know, to OB-GYN. So perhaps something of interest there to us. But again, as of right now, we are supportive of excluding OB-GYNs.
Thank you, Joe. We can dig into and follow up with the healthcare payments database team about what types of analysis might be feasible and try to come back to this group with information. So Janice, go ahead.
Yeah, just to add, after the reading of one portion of the statute in which it is mentioned that OB-GYNs can be considered one's primary care doctor. A reminder to folks that at the last meeting, DMHC did explain that OB-GYNs can choose to be designated as primary care physicians on the provider directory, so that people seeking their primary care may in fact only be seeing an OB-GYN for those needs. And it seems that the money that is spent on that way, the money that is spent on that care provided to those set of patients shouldn't be excluded from the calculation of what is primary care. And to the comment made about differential payments, you bill the same codes. And so, for instance, in the Medi-Cal system, if you're billing the same code for the same services, you're getting paid the exact same dollar amount, whether you're whether you're a OB-GYN or whether you're another type of primary care physician.
Thank you, Janice. And Bill, did you want to jump in?
I don't hear Bill.
Bill, you may be muted, or I can't see you on my screen. Okay. Bill, we'll come back to you. Oh, sorry. Maybe it looks like he's calling in. Bill, can you hear us, or can you unmute yourself now? Okay, bummer. Sorry, Bill, we will come back to you. We'll try to figure out the tech here and come back to you. So thank you all for.
Margaretta, hi,
Oh.
This is Mohit. I just want to chime
Yeah.
in really quick in support of where we ended up. I think at least understanding what we are measuring is important, and I completely appreciate the definitions that we've been discussing for several months now about how do we want to view the future of primary care. But I also believe that given that there are accelerated adoption metrics being considered, or measures being considered, and the focus on the spend and how to adjust the spend over time, we need to have those two views, quite frankly, of what it means if the definition is expanded. I mean, if the primary care code is being paid, then it's primary care. I mean, I don't know what other definition we could have, and I understand that we want to get to a different place, but if we don't know our starting point, how are we going to ever get there? So I'm just going to, because I appreciate the discussion.
Thank you, Mohit. Okay. Maybe one more time, Bill. Can you unmute?
I'll try it now. Can you hear me, Margaretta?
Yes, thank you.
Okay, all right. Sorry, I was dialed in by phone. So I totally support what we're trying to do here. I support the holistic care position, but what the point I'm trying to make here is that in Medi-Cal, which affects 14 million people in California, the new TRI rates are being applied beyond the 3 categories to any provider who bills under the applicable 790 plus codes. So for MCP plans like Anthem and Promise and HealthNet and IEHP and LA Care, all of that claim volume is going to include increased spending on primary care codes that can be billed by any type of provider who bills under those codes. So if we have OBGYNs billing under those codes that count toward primary care, we're going to have to spend at the plan level and the delegated model level that extra money, and we're not going to be credited for it under this policy. And that's a conflict, and it needs to be resolved.
Thank you, Bill. We just had a question in the chat if you could explain the TRI and MTP to the group.
You see, that's the problem. The MCO tax is an initiative being undertaken by Department of Healthcare Services in Medi-Cal. It is raising rates for some providers as much as 20 to 25%. So this is a huge increase in spending. That increase in spending should be counted toward primary care for the 14 million lives in Medi-Cal. And if this definition excludes many of the claims, we're going to lose out tremendously. We're still going to have to spend the money on the Medi-Cal side, but it's not going to be counted toward this standard. And I fear that plans and groups who are delegated are going to get dinged for that.
Thank you, Bill. We can, I think this maybe is an issue that, we, OHCA can follow up with a DHCS on, and to understand the implications for the primary care definition. And we can come back to this group and kind of have more conversations about this. So thank you for the flag. And thank you for all of the feedback around this decision of whether to include or exclude OBGYNs in our definition. Really appreciate all of the different feedback and the different perspectives. So I think we'll continue to iterate on this, and we'll share again, a formal definition with the board in April. Or sorry, a recommended definition to the board in April based on all of the feedback that we got today. And I know we only have about 30 minutes left, but we had 2 different pieces we wanted to get through today if we can. So I'll turn it back to Debbie to walk through these next few slides.
Thanks, Margaretta. I'll try to be quick on this. So these next 2 slides provide a high-level overview of OHCA's recommendations for measuring primary care investment paid via non-claims using the expanded framework categories. The first 2 recommendations are that for Category 1, which includes population health and practice infrastructure payments, and Category 2, which is performance payments, that the approach for those 2 categories is the same, in that all non-claims payments are allocated to primary care when they're paid in support of primary care programs. Examples of such programs would include care management, care coordination, and population health. Performance incentives in recognition of quality or outcomes of patients attributed to primary care providers would also be included. Meanwhile, payers would be required to limit the portion of practice transformation and IT infrastructure payments that count as primary care to 1% of total medical expense. For Category 3 shared savings payments, the portion of the risk settlement payment allocated to primary care would be limited to the same proportion that claims-based professional spend represents as a percent of claims-based professional plus hospital spending. Next slide. And then for Category 4 capitation payments, the approach depends on the type of capitation payment. For primary care capitation, 100% of that would be allocated to primary care. And then for other capitation payments, data submitters would calculate a fee-for-service equivalent based on a fee schedule for primary care services multiplied by the number of primary care encounters. The next slide will explain that further. So here we see this equation that explains how that works. In the top box, primary care capitation payments are included in their entirety. And then the equation in the center of the slide calculates the total number of primary care services that meet OHCA's definition times the fee-for-service equivalent for that service taken from a fee schedule. The fee schedule specify fees for each primary care service broken down by payer type, commercial, Medicaid, et cetera, and geographic region and year. So each combination of the 4 elements that are within the oval on that slide, the year, the region, the OHCA fee-for-service primary care definition, and the payer type, is considered a different segment. And then the process of estimating primary care spend by counting encounters and multiplying by fee schedule amounts is repeated for each type of capitation: professional, behavioral health, and global capitation, as well as payments to integrated comprehensive payment and delivery systems. So those are subcategories 4B through 4F in the expanded framework. And we've excluded facility capitation payments from this calculation. So you add up these amounts to arrive at the total primary care spend paid via capitation. And then together with the amount calculated from claims, the result is the numerator for total primary care spend. And the denominator is the total medical expenditures. Next slide. So the advisory committee members yesterday commented on this topic, and they highlighted that information on the portion of capitation payments that is actually spent on primary care is typically known at the provider organization level, but not known by payers. A member mentioned that capitation payments cover organization level spending on primary care that's not quantified by encounters and therefore doesn't have a corresponding fee-for-service equivalent, and that those payments should be considered. So some examples of non-encounter-based ways that provider organizations allocate capitation payments include population health management activities, payments to non-billable providers, and pay-for-performance programs that are managed within the provider organization itself. So members noted that measuring these downstream payments within physician organizations would require additional flexible data collection, and recommended that OHCA include investigating such data collection, longer-term planning. Next slide. So now we'll pause for discussion of these questions on the slide and any other feedback you have. So what feedback do you have about primary care spend calculations for payments via capitation specifically? And are there other suggested approaches for determining this spend calculation? And I also just wanted to specifically invite Blue Shield to give us some further information about their proposed approach, which they mentioned at last month's meeting. So Angela, maybe you want to start us off and then we can open it up for general discussion.
Sure. If you don't mind going back to the formula slide. Thank you. Yeah. So our thinking is that, the capitation rate, with HMO being in the system for decades now, the capitation rate is no longer really connected to the underlying encounter count. And, like I think you were saying, there's really not a fee schedule that corresponds to the development of the capitation rate anymore. So, we do feel that by just, using some sort of arbitrary fee-for-service equivalent fee to reprice these encounters, it most likely will truly represent the primary care spend in the capitation environment. So I think, one proposal that we thought of is, I think at the end of the day, what we're trying to get to is out of the professional capitation that we pay, what percentage of that is actually for primary care services, right? Spend. So, what we could do is we can reprice the primary care services in the encounter data, and then take a ratio of that of the total repriced encounters. So basically, you're using a fee-for-service equivalence approach to establish a primary care spend percentage out of all of those services encounters that's actually covered under the capitation. And then you take that ratio and multiply it by the professional cap itself. So in essence, you are proportionating what the true primary care spend percentage is of the actual professional cap payment that's paid to the providers. So we feel like that's a better way to really establishing the more true primary care capitation payment for this purpose. And I believe that this approach is very similar, if not identical, to what IHA has been doing in the past. And so I don't know if Dolores wanted to chime in as well. But we do want to caution against just using the repriced encounter, primary care encounter as is, because we do believe that there is a disconnect between that and the actual capitation paid.
Yeah, I'll just say a few words. I think you're right, Angela. The way we calculated it was a little different math, but the math ends up in the same place as what you just suggested. And I think what you suggested might be easier to understand. So I like your approach. I will just say that when, according to IHA data, when you compare the total capitation amount actually paid and compare it to the sum of the fee-for-service equivalents for all services under capitation, generally, the capitation is higher than the sum of the fee-for-service equivalents. So if we're just applying fee-for-service equivalents to primary care services and not really thinking about what proportion of total services the primary care services are representing, we may be underestimating primary care spending. So I think it's just, like you said, the fee schedule or the capitation is not really based on a fee schedule and the number of encounters that were delivered or anything like that. And so it just that connection's not there, and we need to try to make a connection to it to make sure that we're reflecting actual payments.
Thank you, Dolores and Angela. Do other folks have reactions to, the proposals, and I think especially would be interested in how feasible folks, especially payers, in your data submission, do you think some type of approach, as Angela mentioned, would be feasible? And in general, any other feedback from the work group? Yeah.
Yeah, this is Mohit. I just wanted to think this through maybe a little bit more, and we're happy to do that, because when my fear is that this is more about the availability of and the granularity of the data that is made available even to payers, and that if encounters aren't flowing right and other things aren't happening, no matter what the formula is, you're not going to get to a relatively correct response here, right? So I think, again, these are areas we all agree with that need to happen. We need to understand these things better. But I would hate for us to create a system or a rubric of looking at these things and then not be able to deliver because the system simply hasn't gotten to that point yet. Or if we're looking at investments that need to be made, again, we run up against the 3% cost benchmark that we're facing. So how do we account for the investments that need to be made if you can't exceed 3% trend in any given year with all the build that might be necessary? So I just want to, again, put things in context. Any of these investments don't just sit in a silo. They all apply to the 3% trend that we have to now face in the benchmark.
Thanks, Mohit. So I think maybe if folks have other suggestions or recommendations, welcome those now. But maybe what makes sense for us to do is to also do a meeting with some of the payers and kind of get together and think through these different formulas and how what makes sense overall. Does anyone else have any other feedback or suggestions for next steps? Yes, Adam, go ahead.
So I agree with the comments that have been made. The goal here is to capture the spend for that for non-claims care, and yet the benchmark put here is based on claims-based care, and the services that we're looking for are outside of that, and frequently in capitation that covers those additional payments for services. And so I think it's a reasonable recommendation. I need to think about it a little bit more, but to look at this percentage based on the capitation amounts as opposed to the total numbers here. I have one other comment back on slide 17. Sorry, when we had talked about this earlier, on the bottom for category 3, it's not claims-based professional and hospital spend, it's institutional spend, because institutional spend is broader than just hospital, SNF and home health and other services like that. And that's the divide: professional and institutional, not professional and hospital. Maybe a minor point, but I think it's important.
Thanks. And Mary Jo, did you want to share?
Yeah, just quickly, I just wanted to mention that the reason for that change is that we essentially need to work within the construct of data collection that OHCA already has in the various categories that it already has. So Adam, we can certainly circle back with you and show you those categories and see if there's anything else that you think should be added to that denominator. But essentially, that's why that phrasing or that language is the way it is. You're absolutely right. It is a little bit different, but need to sort of work within the existing construct.
Thank you, Mary Jo. So I think since we have about a little bit more than 15 minutes left, we'll do some follow-up offline with folks to discuss the how to allocate primary care spend under capitation, and we'll follow up on that and have some more discussion. And then in this last portion of the of our meeting today, wanted to walk through options we presented in our last meeting for primary care investment benchmarks, and again share the advisory committee feedback that we received. I'll probably try to move really quickly through many of these slides initially. So on this slide, this essentially outlines 4 states that are working on primary care investment and have set primary care investment benchmarks, how they are approaching a variety of questions and decisions related to setting those benchmarks. And then we've added the California row, or kind of, the OHCA preliminary recommendation row in the front there. So initially, we're thinking that the benchmark would apply to all payer types, so commercial, Medicaid, and Medicare Advantage. Looking at and want your feedback today, again, on a single or separate benchmarks by age group, looking at a % spend, and then also looking at an absolute benchmark with relative improvement benchmarks leading up to that absolute benchmark. And then the specific numbers for the benchmark are, again, under discussion, and we would like your feedback on those and the 2 options we shared with the advisory committee. So this is data that we shared previously, I believe, just showing the commercial spend in California for Medicare Advantage, commercial adult, commercial children, and then commercial full population to give you a sense of the current state based on the Integrated Healthcare Association analysis and the definition in the CHCF report on primary care spending in California. And I think the emphasis here is that using the primary care provider identification approach of kind of that 2-step process, we would likely get lower results using the OHCA methodology than was in the methodology used in this reporting. So jumping to our proposals for relative improvement benchmarks and 2 options for absolute benchmarks. So here, for the relative improvement benchmark, we are proposing that payers increase their primary care spending by 0.5 to 1% per year, depending on their current investment. And that once payers reach the absolute statewide benchmark, that they could opt to maintain their current primary care spend level. And so this relative improvement benchmark is consistent with the benchmarks in other states, like you saw in a previous slide, and also recognizes that kind of this is a steady transformation growth of shifting payments towards primary care and away from other sites of care or other low-value care towards primary care. And it reflects that kind of gradual reallocation while also working towards affordability goals. And then we shared with the advisory committee, and these are the benchmarks we shared in our last work group. So 2 options for an absolute benchmark. So this option is 15% of total medical expense allocated to primary care by 2034 across all payers and populations. Really intended to reflect high primary care spending in other systems internationally that have high primary care spending and results, and then also reflects delivery goals, our delivery system, younger population, and the 10-year time horizon that we are working towards. So we're thinking that this 10-year time horizon provides time for that gradual reallocation and redistribution of spend towards primary care. And then the second option is an option with different benchmarks for adults and pediatrics. So again, this goes back to kind of the differences in the current spending that we're seeing across adult and pediatric populations. So this option proposes a 12% absolute benchmark for adults and a 24% benchmark for pediatrics. So, and here this would kind of look to understand those differences across population and recognize that optimal primary care spend does look different for children and adults. And again, the primary care spending using the OHCA methodology approach of primary care providers identified in the DMHC network reports would likely lead to lower lower baseline analysis than the current results. The other key piece we wanted to mention here is that this approach also adds significant data submitter burden, or could add significant data submitter burden depending on how we approach it, especially for non-claims payments. I think as we've been talking about, non-claims payments, especially capitation, are allocated to a full population and could be quite challenging to break out across adults and pediatrics. Another example would be, if you had a shared savings arrangement for a hip or knee replacement, how do you make sure in the data that that only counts towards adult spending? Or, the portion of that that may be tied to primary care is included for adults, excluded for children. So that may not be the best example, but that's kind of those are the decisions we're kind of thinking through. So wanted to stop there for questions and discussions. Oh, sorry, one more slide. And I think, again, this just reiterates the challenges of non-claims primary care payments by age group. So getting to our advisory committee feedback. So advisory committee members were in support of option 2, so a separate adult and pediatric benchmark. Many members, emphasize the need for separate benchmarks to account for those differences in practice populations, differences in the spending that we currently see. And then a few members, again, emphasized that a single benchmark may have an unintended consequence for shifting spending away from pediatric primary care, and really emphasized the need to focus on pediatric primary care. And in general, the main feedback we heard on the 10-year horizon was that change takes time, and that we should allow for that in terms of the time we are setting to achieve these benchmarks. So getting to our discussion questions. So welcome any feedback on what we have raised so far, especially, how do we balance targets that represent optimal spending for age groups versus data submitter burden? And then, if we look to set a single absolute benchmark, is 15% the right amount? If we look to set separate benchmarks by adult and children, are 12 and 24% the right amounts? And then interested in feedback on the 10-year timeline. So it looks like, Kevin, you have your hand raised. Go ahead.
Yeah, thanks. I really appreciate the thoughtfulness behind this. So let me address several of these questions. The first is the whether to have separate benchmarks for children and youth compared with adults, or even 3 tiers for older adults versus less old adults. I think, having seen the wonderful data that you all presented last time, empirically, clearly there are differences in spending that track with age. And I think it's largely a denominator issue, not a numerator issue, just to remember. It's, kids tend to be healthy, thank goodness, and they just don't have a whole lot of hospital expenditures and specialty and imaging. So, I think it's just a lot more of care of children and youth is primary care, preventive care, and fortunately not a lot of acute care services. So there's a real logic and a face validity to that. And if we were in a world of all claims data, it'd be fairly easy to just parse it out and say, okay, for health plan A, you could say, there's a target for adults and a target for children and youth, and you could then see what's the enrollment in that health plan, and then you could just come up with a weighted target, right? And say, oh, this health plan has 20% enrollees under 18 and 80% over that. So it'll be a weighted average of 80% of the adult target plus 20% of the, younger age target. The problem is, so I was thinking, oh, maybe this wouldn't be so complicated, but I think Margaretta's, it's the non-claim stuff that then becomes a real mess for all the reasons you're talking about. So there's I mean, we were just talking about how difficult it is to kind of come up with, estimates of non-claims expenditures that really get tracked into primary care, and it becomes almost, just a nightmare then if you're going to try to do it for non-claims payments with all the, things like you're saying, bundled payments for a joint replacement or something like that. So I think here's another one that I probably put this in the to be studied category. I think it would be innovative because most states have not done age-specific kind of goals for primary care spend. Maybe start saying, well, let's come up with just the overall percent, and moving forward, just think through the technical specifications that would be required to be able to fully do accounting, to be able to look at some age-specific bands of total spending. So that'd be my proposal. Then on the total spend, I think 15% sounds right to me. Looking at the data that's been presented, I would put that out there. So I'm very supportive of that. I think that 10 years seems a long time to me, and primary care seems to be just disintegrating in front of our very eyes, and I worry about taking 10 years. On the other hand, I think if it's a reasonably ambitious goal, I would sort of balance that with 10 years. I think if we put out there 15%, it would send a strong message that would temper a little bit of the sense of urgency out there in primary care to get sort of investment done sooner rather than later. If it was anything less than 15%, then I would really reconsider the timeline to be shorter. So those are mine. Just to summarize, I think age-specific things make sense, but technically hard, and maybe to put that into a second level of goal for this work. 15% sounds right in 10 years, as long as we're aiming for 15% as the goal. Thanks.
Thank you, Kevin. Appreciate all of that thorough feedback. And Adam, go ahead.
I really appreciate Kevin's point around the burden of separating out the age groups, especially in those non-claims payments. And that, I think it's a very good point. So just for just thinking it through on the provider side, kids in general have a pediatrician. At the beginning of life, they need a bunch of vaccines, and they need to come in for well checks. They get established with a pediatrician. They generally have a primary care provider. In general, the whole OB or other non-primary care provider becoming the primary care provider tends not to be as much of an issue in those kids. And pediatricians also tend not to refer to specialists as much, but when those kids need specialty care, it tends to be incredibly expensive. And as we get towards some more of the genetics-based testing and treatments, those costs can be astronomical. All that to say that I think moving the pediatric, if we were to separate things out, moving the pediatric benchmark up significantly from where it is, I think is a bit of a stretch. I don't think there is that much of a dearth of primary care being provided to these kids. And when they need that specialty care, it ends up skewing things in that direction. On the overall benchmark, and I may be missing some data, but from what I recall, when we look internationally, we see a range of 12 to 15% of what their definition says is primary care. So 15% is in the high end of other countries' spend in a definition that I don't know if it overlaps with our definition. And so if we have a different definition and we're going to make our target one that is a much broader definition and the highest end of the benchmark, we may be setting a benchmark that is not necessarily reachable. And then lastly, I agree with ideally, if we could shorten the timeline a little bit, that would be great to push things. But there are a lot of changes that we're discussing that need to be implemented over time, and time does pass relatively quickly. So I wouldn't say cut it to 5 years, but somewhere in that 7 to 10 year range probably is reasonable.
Thank you, Adam. Do other folks have reactions or suggestions to these questions?
Just as you consider this, I want to raise the point that Children Now raised yesterday, that they wouldn't want having a single benchmark to inadvertently result in kids getting less primary care. So, and I'm you know, respecting everything that Kevin said and Adam said and the difficulties of separating the two. So.
Yeah, thanks, Beth. Yeah, we definitely do not want that as an outcome of this work. And we can, even if maybe we end up with a single benchmark, we can look into how we might be able to monitor spend across populations using some supplemental analysis. Catherine, go ahead.
Thanks, Margaret. I'll send some thoughts on the differential of ages later because I know we're short on time. One other factor that I think is important to consider around is 15% the right percentage and is 10 years the right time horizon is the fact that unlike several of the other states that were on the slide you just presented, these are advisory. They're not enforceable. There will not be financial penalties for plans that do not make the percentage, whatever is selected, and there will not be insurance product bans or insurance product penalties. So I think that allows us some space to be still realistic, still practical, but a little bit more aspirational than some of the other states, both in terms of time horizon, how long it'll take us to get there, and the percent that is selected, because you don't have to necessarily be in a position of thinking, will everyone make it and what are the outcomes and political, you know, challenges of the penalty system, the enforceability mechanism. So I think that's just important to keep in mind. And then also really want to call out an appreciation for the fact that it's not just an absolute benchmark. We can discuss if it's 15 or 14 or 16, whatever it be, but there is this stair-step approach, right? That's still that relative aspect of improvement. And I think that's also a factor in, you know, is 10 years too long or just about right? I had the same sort of gut reaction as advisory councils of like, we need 5, you know, 7's better than 10, but there's a lot of factors in there. So just wanted to put those out as 2 other pieces to think, and then I'll put in some more detailed comments in the chat box. Thank you.
Thank you, Catherine. And I think we saw a few comments in the chat, and I think we definitely, as OHCA, we recognize that, you know, in order to meet the 3% spending growth target and meet the, you know, long-term 15% primary care investment target, if that's where we land, does require a redistribution of spend, reallocation towards primary care away from other spending. And I think that is, you know, part of the effort is to really increase investment in primary care and shift pay, you know, spend to primary care to emphasize, you know, all of the things we've been talking about in our vision. So I know we are 1 minute over times and really appreciate all of the rich discussion we've had today. If you all have additional feedback or thoughts on, you know, each of these discussion questions that we've laid out on the side, please send those to us. We really appreciate all of the feedback that you have. And, you know, want to recognize and emphasize that these are not easy choices and that there's, you know, kind of a lot of nuance in all of the work that we are doing here on setting primary care definitions and benchmarks. So I appreciate you all digging into this with us, and we'll follow up and, you know, let you know where we are before we present to the board in April, and welcome any feedback before then. So thank you all for a great discussion today, and we will talk to you soon.